In my presentation in the North American Lung Cancer Congress, we have the opportunity to discuss on role of liquid biopsy, specifically in monitoring. And we know that liquid biopsy monitoring is an important tool for the assessment of the patients, actually not only in targeted therapies, but also in immunotherapies. There are some data that we can use to follow the patients, specifically the dynamics of the variant of allelic fraction, that I think is really interesting data. Demonstrated that patients that have dynamics of the allelic fraction variation decreasing have as a surrogate and an impact in the overall survival and progression-free survival. We had also the opportunity to discuss in the presentation some studies coming for early stage or we say locally advanced stage 3, in patients, for example, that are receiving consolidation of immunotherapy, how also liquid biopsy is able to distinguish between patients that are in complete response from the point of view of the ctDNA in circulations compared with patients that are in increase still or presence of ctDNA, and how this will be impacting in their outcomes. Another important discussion that we have, and actually is one of the clinical questions that every clinician have, is when we need to stop the treatment immunotherapy after 2 years. For this, and this is a very difficult conversation sometimes with patients, liquid biopsy could be a tool to identify the patients at risk of progressions after long-term response. And actually, that was a paper published from the group of Hellman in Clinical Cancer Research in 2020. Recently, and that was in August 2022, we have a publication coming out from the group of Dr. Allen that was discussing about the change in circulating DNA that reflect the benefit in a pool analysis that was putting together 5 different independent trials and seeing which different time points in the collecting the blood, that the ctDNA might serve as an important tool for clinical development and early indicator of treatment benefit in all these groups, and actually impacting overall survival and progression-free survival. Finally, we discuss our own data that we have generated in our lab and recent publication regarding to the dynamics of PD-L1, but in this case, taking in the membrane of the extracellular vesicles that are very important members of the liquid biopsy family. And we did this in a training and invalidation cohort, adding in some in the training cohort an important integration of the radiomics, that is improving the model in accuracy to detect patients that are longer responders. But also the discussion was in a recent data that is under review at this moment, that is the TGF-beta as a biomarker, as a single biomarker, not in dynamics like we did with the PD-L1, but it's in the baseline determination, intra-extracellular vesicles or in circulation. This TGF-beta was able to distinguish between patients that are having an outcome in survival, specifically when they are treated with immunocheckpoint inhibitors. So patients have a high expression of this TGF-beta in the extracellular vesicles from the very beginning. They are not responding as the ones that are decreasing or having low levels at the beginning. And some of the questions that we continue to have is how we can integrate the liquid biopsy in the clinical trials properly, and specifically in the scenario that we are going now to face, that is adjuvant treatment. We know that there are some drugs approved by, there's some opportunities for patients that are having resected non-small cell lung cancer, receiving immunotherapy, and they are the data that we have with tumor-informed approach. The plasma collection was not really the best in time points. We only had in this study I'm referring to the study Power 010, we have only the plasma collection after the surgery. So we don't have data before, and that is an opportunity to lose some patients now in the analysis, because there are patients that are not cheaters, for example. So, and even though the data that we have for the ctDNA positive and negative, in the group of negative, and that was a great discussion that Dr. Heather Wakili was having in the closing keynote presentation, that she say, actually, we don't know what happened in this patient with ctDNA negative, that they are not going even well. So we would like to have a method that is distinguishing liquid biopsy between the people who really need the adjuvant treatment and the ones that are not needed. So in conclusion, we will say that ctDNA, in all this discussion and the table discussion that we have, ctDNA is a perfect tool for monitoring. Monitoring is applicable from the metastatic to the minimal residual disease. There are a lot of work to do, and was also a nice presentation of Dr. Lesia Sequest about the early detection. And there we will have also in early detection a lot of opportunity to monitor these patients in the follow-up of the screening. But also we need to think or open the mind to biomarkers that are coming from other members of the liquid biopsy beyond the ctDNA, and there looks like exosomes or CTCs or platelets that could be a promising opportunity for detection of these patients in terms of monitoring and recurrence.